Sir, Yen doctor, she's fine, sir. She's good, sir.
Yeah.
We'll be streaming this on YouTube also, sir. So I've just started the live stream. We'll wait for everybody another 3 minutes and we'll start, sir, once they're all here.
Good evening, Professor Prasad Manik.
Hello, sir.
Well, hello.
Sir,
Good evening.
how are
Good
you?
evening.
Good
I
evening,
am
sir.
okay. Fine. I'm in USA, Westport, Connecticut.
Oh, okay.
Because of Green Card, I have to be
Nice.
here compulsorily for more than 6 months.
Nice to see you, sir. After a long time.
I'm also very happy. I'm attending most of the webinars because there is initially it was cold and winter and it was difficult to walk and all. Now I make it a point to learn from all of you.
So you are a good clinical teacher, sir. So I think these children, students, they should learn from you. I think.
No, not at all. Yeah. These days, the only thing I gave a small advice: just don't take the case sheet photograph and put it in the slide. You make your own slides and don't leave empty space. And then the font size should be proper and it must be Arial black or something which is visible to everybody. That's the
Yes, sir.
only advice I made, because recently I find that cluttering of this thing. Just take photograph of this thing and put it in the case sheet.
Sir, good
Yeah, it's
evening, sir.
important.
Good evening.
Sudhakar, good evening. Good
Yes,
evening.
sir. Good evening, sir.
Good evening.
Unga presence or blessing, sir.
Yeah. Thank you, sir.
Dr. Maniram, good evening. Dr. Prasad
Good evening,
Mani, good evening, sir.
Sir, good evening, sir.
Good evening, sir.
Good evening, sir.
Good evening, sir.
Good evening all. SPS sir நாங்க இப்பதான் அனுப்புனோம். We'll wait for Dr. S. Balasubramanian sir and we'll start it, sir.
Good evening, Bala.
Good evening, sir.
Oh, sir is here. Sir is here.
சாருங்கிற என்ன? I am a student. நீங்க தான்
SBS
சார்.
sir, good evening, sir.
Lakshmi sir வந்துட்டாங்கல்ல? Can we?
Sir வந்தாச்சு. We'll just start. We'll just start, sir.
Yeah.
Sorry,
Sir, we have to apologize, sir. Sir, we have to apologize. We should have reminded you already. You will be very busy with so many programs. It is our mistake.
Today, some 4 or 5 webinars are there at the same time.
Good evening, everybody. On behalf of the IAP Chennai City branch, it's my honor and privilege to welcome you all to this session 5 on pediatric cardiology, recent updates. So RUPE, we've been conducting this from February on under the convenership of our legendary teacher, SBS sir. Our pranams to you, sir. What RUPE is today, it is completely because of your unstinted support. We are grateful to you for that. Now, when you look at pediatric cardiology as a specialty, it is very fascinating because historically, I think several iconic advances are part of its evolution. So right from palliation, your BT shunt, or the wonder drug prostaglandin for drug-dependent circulation, cardiopulmonary bypass, you name it, you have it. So you've come a long way, and it has evolved from simply listening to murmurs using a stethoscope to repairing defects through a catheter, and now precision medicine, AI guidance for prognostication. So we have come so far. And this is exactly the theme of today, recent updates in pediatric cardiology. May I request our President, Sudhakar sir, to offer his introductory remarks, followed by words of wisdom from SBS sir, which will later on be followed by our mentor, Maniram sir, who will take over the proceedings with 2 wonderful students who are here with us today. Thank you. Over to Sudhakar sir.
Good evening, everyone. And really, it is a very pleasure to welcome you all for the recent updates in pediatric education. Actually, this program aims to provide an overview of latest advances, emerging evidences, and evolving clinical practice in various things. The topics are chosen by none other than our SBS sir. Really, we are honored to have sir with us to guide us in this program. And today, we are really honored to have the distinguished faculty, Dr. Maniram, the senior cardiologist, to guide his students and talk about the latest advances, updates in the pediatric cardiology. And thank you, Dr. Prasad Mane, to be our special guest and give an overview about the updates in the pediatric cardiology. Thank you all for joining us, and wish you really productive and informative sessions. Thank you, sir.
May I request SBS sir to offer his words of wisdom today.
Thank you, Ma. At the outset, I'm very happy that today's program is on pediatric cardiology. Well, I have more reasons to be happy. The most notable reasons being this is being conducted by none other than Dr. Maniram Krishna. They are one of the finest postgraduates in pediatrics from KKCTH. And I still remember, it's always said that, teachers not only learn from patients, not only teach, but they also learn from students. Good students like Maniram. right? I'm very, very happy that he's doing a great job in Tanjavur, my home district. In fact, I should have settled down in Tanjavur instead of Chennai, I have regrets even today. And of course, the other reason why I'm happy is because there's another gentleman, Dr. Prasad Mane, excellent pediatric, no-nonsense cardiologist. That's what is the best way to describe Dr. Prasad Mane. I mean, he's so efficient and so cool, right? And his echocardiographic skills are outstanding. He counsels parents very well. His clinical approach, he is somebody who spends time in taking history and completing a physical examination before he does an echo. That's sort of a clinical cardiologist. I'm happy this combination will be as effective as Lillian Thompson. Over to Dr. Lakshmi. Thank you very much.
Thank you so much, sir. Without further ado, I think it's time for Dr. Maniram to hog the limelight with his students he has mentored so wonderfully. Over to you, sir.
Thank you, ma'am. Thank you, IUP Chennai City branch for this opportunity. And SBS, sir. So, sir, தான் எனக்கு first cardiology ஒரு interest பண்ணது. And my thesis, sir was my thesis guide. And he only chose topic of Kawasaki disease, which is where interest in cardiology came up. So, another sir சொல்லி இந்த இது பண்றது, it's even more special for me. And then before we go to the presentations, I should appreciate both Viveka and Thirukumaran. சாருக்கு நல்லா தெரியும், நான் எப்பொழுதுமே எல்லா ஸ்லைட்ஸும் லாஸ்ட் மினிட்ல தான் முடிப்பேன். ப்ரெசன்டேஷன் இருக்குன்னா 1 hour முன்னாடி தான் முடிப்பேன். பட் அவங்க they've been really chasing me for the last whole week. And நான் லாஸ்ட் மினிட்ல தான் பண்ணேன். நேத்தி தான் அவங்களுக்கு ஸ்லைட்ஸ் கொடுத்தேன். But still both of them went through all the slides, immediately came back with their doubts and then added to it. So we will start with the first presentation. And Dr. Viveka, you can start your presentation and then we'll take it from there.
Good evening, sir. Good evening to all the wonderful teachers here. Being a first-year postgraduate, to even share the same space as all these wonderful teachers, I'm really very happy and honored to be a part of this presentation. I'll start sharing the screen. So very good evening. This presentation is recent updates in pediatric education, mainly focused on pediatric cardiology. I'm starting with the genetics part. I'm Dr. Viveka, first year pediatrics PG from Tanjavur Medical College. Over to Dr. Maniram sir for the first few slides.
So actually, we have been given 2 topics. First is cardiac genetics and the other is interventions. So, like whenever we tell about a child who has a cardiac problem as well as a genetic problem, the first thought anybody will have is, already has a heart disease. Or should we be worried about genetics? But that is not the case at all. Actually, genetics is not just about making a fancy diagnosis. It is about making a difference in the treatment of not just the child, but the entire family. That is what we hope to illustrate through some case-based scenarios. Okay, next slide. So we actually live in the era of precision medicine. Okay, so genetics is not just about making a diagnosis or maybe even writing a paper or a case report. Okay, it is about day-to-day management of the child. Next slide. So these are the 3 big subsets where genetics plays an important role as far as cardiac conditions are concerned. The first is chromosomal disorders. So most of these all of us would be familiar with. Trisomy 21, trisomy 18, Turner syndrome, Dijot syndrome, Williams syndrome. So that is not going to be the main focus today. The main focus is the middle one, so which is single gene disorders, which result in heart problems. So of these, there are 4 major subsets. The first is cardiomyopathies. These are probably the biggest subset of genetic cardiovascular disease. Second is channelopathies or inherited arrhythmias. The third is iotopathies, which includes Marfan syndrome, Loeys syndrome, as well as many other conditions, including vascular Ehlers-Danlos syndrome. And the fourth is congenital heart disease and genetics. There's also a small subset of mitochondrial disorders, which can either present as cardiomyopathy or conduction disorders, but these are much less common compared to the second subset. So that is the part which we are going to focus primarily on during today's presentation. Yeah. Viveka, you can take over.
Yes, sir. So the first clinical case. So a 4-month-old male infant presented with feeding difficulty and suboptimal weight gain. On examination, there was fast breathing with subcostal retractions, ejection systolic murmur at the base, and soft dysmorphic features were present. This is the echo of the baby. Here we can see the left ventricular lateral wall hypertrophy and the septal hypertrophy. And here we can see mitral regurgitation and the left ventricular outflow tract obstruction. And here we can see the grossly hypertrophied left ventricle and a small left ventricular cavity. And again, in this view, we can see the left ventricular outflow tract obstruction. And here we can see that the peak pressure gradient is 51 mmHg, which indicates there's a moderate outflow tract obstruction. And here we can see that the interventricular septal dimension is 8.7 mm, whereas the normal for this age is 3 to 4 mm. Similarly, the lateral wall dimensions is 18.3 mm, whereas the normal is 4 mm. And we can see the grossly enlarged left ventricular mass, which is 80.7 grams. And this is the ECG of the child. We can see the heart rate is 126, and there is a left as a normal rhythm and sinus rhythm, and there is a left axis deviation, and we can see the left ventricular hypertrophy in this ECG.
We will just stop for a second here. Okay.
Yes, sir.
So actually, this is hypertrophic cardiomyopathy, but there are a lot of clinical things which we can take from this case actually. So generally, when you have infantile severe ventricular hypertrophy, it is different from what we see in HCM in adults. Okay, all the time we see, we hear about cases where somebody was running in a marathon, then collapsed and died, or some young person was in the gym and suddenly collapsed and died. So majority of these will be some kind of genetic cardiovascular diseases. They will not be MI, especially in young people. And in that, the biggest chunk is hypertrophic cardiomyopathy. Okay, so these hypertrophic cardiomyopathies are due to something called sarcomeric gene variants. Whereas in an infant, when you see severe hypertrophy, it is usually non-sarcomeric. Less than 10% are sarcomeric, more than 90% are non-sarcomeric. And even in that, when you see so much hypertrophy of both the free wall as well as the septum. So generally in sarcomeric, the septum is only more involved. So whenever you see such hypertrophy of both the free wall as well as the septum, there are only two sets of differential diagnosis. The first is storage disorders, of which Pompey's is the commonest. And the second is a type of Noonan syndrome, which is called Noonan syndrome with multiple lentiginous or NSML. So previously it was called as leopard syndrome. Okay. So between these also, you can make a differentiation based on the ECG. In NSML, there will be typically left axis deviation. Whereas in Pompey's or in most of the storage disorders, there will be either normal axis or right axis. And in Pompey's, the PR interval will be very short. So as soon as we see the child in clinic, so as soon as we have examined the child, got an ECG and an echo, we can make a diagnosis actually. So in this patient, in this child, the only differential diagnosis we had at the end of the clinic visit was Noonan syndrome with multiple lentiginous. Okay, and we were able to make this diagnosis only because of a phenotype-genotype correlation. So it is important that we, it is not just the echo. It is about the clinical examination, the ECG, as well as the echocardiogram. So you need to pay attention to all of these features if you want to make a correct diagnosis. Okay. Next.
Yes. So initial management was started for this hypertrophic cardiomyopathy. It was started on beta blockers at a dose of 4 mg per kg per day. Later, it was increased to 7 mg per kg per day. And then the baseline anti-pro-BNP levels was measured, which was 30,000 picogram per ml. And there was no significant improvement in the symptoms in 4 weeks following this treatment. So following which, as Sir suspected this Noonan syndrome multiple lentigens variant, genotypic testing, genetic testing was sent for this patient. And this is the genetic analysis report. And specifically, they have requested to look for RASopathies and glycogen storage disorders. So what are these RASopathies? So RASopathies are RAS MAP kinase, mitogen activated protein kinase pathway defects. This predominantly includes the Noonan syndrome and the Noonan syndrome spectrum disorders. And the glycogen storage disorder, mainly the Pompey's disease, has hypertrophic cardiomyopathy. And for this particular child, it's a 4-month male child, and it also has one sibling death, early death history. And in the report, we can clearly see that it is positive for PTPN11 gene. So in Noonan syndrome, more than 50% of the cases involve this PTPN11 gene mutation. So it is autosomal dominant inheritance. So based on this evidence, particular targeted pharmacotherapy was started for this case. It was started on everolimus at a dose of 0.5 mg daily, and the drug trough levels were monitored every 3 weeks. So following this treatment, this is the echo of this child. We can clearly see that the left ventricular hypertrophy is decreased, and the cavity size also has increased. And these are the values. We can see the dimension initially with the standard, the Z-scores, we can see the interventricular septal dimension. Initially, it was plus 9.5. Later, it is plus 4.2. And then the lateral wall dimension, it is plus 7.2 deviation. And after treatment, we can see it is plus 4.9. And the left ventricular mass, initially, it was 298 gram per meter square. And after treatment, we can see it is 175 gram per meter square. And the NT-proBNP levels, initially, it was more than 30,000 picograms per ml. Later, after treatment, we can see it is 6,140 picograms per ml. So this specific targeted therapy clearly showed improvement in this case, and this made the major change for this case. Going into the case 2, and later we'll explain how this pharmacotherapy works after this second case presentation. Case 2. 3-month-old infant presented with left ventricular hypertrophy was noted in the 3rd trimester antenatal scan itself. And in the neonatal period, it presented with the recurrent arrhythmias. So it was started on amiodarone and beta blockers. And the baby had a poor weight gain, and it had recurrent arrhythmia despite treatment. And this is the ECG of this baby. We can clearly see it has an irregular rhythm, and it is atrial tachycardia. And this is another ECG of this child. We can see it is an irregular rhythm, multifocal atrial tachycardia. So Holter monitoring was done for this baby, and then we can see that the ectopic beats, less than 1% were from ventricular beats, and 29% were supraventricular beats. So it is clearly a case of supraventricular arrhythmia. And this is the echo of the baby. We can see that there is a left ventricular hypertrophy, septal hypertrophy. And these are the dimensions. The interventricular septum is 8.2 mm, and the lateral wall is 5 mm, and the left ventricular mass is 18.7 grams. It is points towards an hypertrophic cardiomyopathy. And then genetic test was done for this baby, and then we found there is a RAF1 mutation. Again, RAF1 mutation is associated with Noonan syndrome. And this is the genetic test report of this baby. And this is one interesting case report they have given, in which this case study, they stated that they have studied the molecular management of the multifocal atrial tachycardia in Noonan syndrome with MEK1 or 2 inhibitors, which is the trametinib. So in this case study, they have studied in day of life 3, a 39-weeker developed multifocal atrial tachycardias. So they started antiarrhythmics for this baby, mainly beta blockers and amiodarone, flecainide. All the antiarrhythmics were going going on. And then, but despite this treatment, the baby constantly developed malignant arrhythmias, multifocal atrial tachycardia, and polymorphic ventricular tachycardias. So, cardioversion, despite all these treatment, it developed 2 cardiac arrest episodes, and it was ventilated in the ICU. So, as the last option for, and then the baby initially it presented with a specific cardiac manifestation in echo. It had the early hypertrophic cardiomyopathy, concentric left ventricular hypertrophy, pulmonary valve stenosis, and the atrial septal defect, and even other clinical features like macrocephaly, widely spaced nipples. All of these pointed towards an RASopathy diagnosis. So, RASopathy sequencing panel was sent for this baby, and it had a RAF1 gene, the same variant, C770C mutation, like similar to our case. So, finally, they have tried MEK1 or 2 inhibitors, which is the trametinib. So, after starting trametinib, in this case, within 48 hours, it returned to sinus rhythm. So, for our case also, sir has started on trametinib at a dose of 0.1 milligram once daily, and it returned to sinus rhythm predominantly by 48 hours. So, this is the ECG of the child after starting trametinib. So, coming to the mechanism of action of both the drugs which we saw earlier. So, in Noonan syndrome Noonan syndrome multi-lentiges variant, on the first looking into the genetic basis, Noonan syndrome has a gain of function mutation. So, in this gain of function mutation, there will be RAF pathway, MEK pathway activation. Here we can see that the RAF pathway, MEK pathway activation. So, here there is it is an hypermetabolic pathway where there is increased phosphatase activity, and there is hyperactivation of the RAS MAP kinase pathway. So, for this, we have to target the MEK inhibitors. So, the MEK inhibitors, here we have used the trametinib. Whereas, in the Noonan syndrome with the multiple lentigens, which is previously known as the Leopard syndrome, the mutation is a loss of function mutation. So, it has a dominant negative effect, and there will be a compensatory upregulation of the P13-AKT mTOR pathway. So, for this group of disorders, we have to use mTOR inhibitors, which are everolimus, sirolimus, and temsirolimus. So, in the first case, it was typical of a Noonan syndrome multiple lentigens variant. So, sir has used mTOR inhibitor. Whereas in the second case, it was typical of typical Noonan syndrome, and it presented with multifocal atrial tachycardias, and sir has used MEK inhibitor trametinib. So, over to Maniram sir regarding cardiomyopathies.
So I think these cases, both of them had very, they were both rasopathies, but the clinical presentation as well as the treatment were completely different, and it was purely based on the genetic diagnosis. So this is just to illustrate the importance of early genetic testing in these conditions. So cardiomyopathies, essentially we have 4 subgroups: hypertrophic cardiomyopathy, dilated cardiomyopathy, restrictive cardiomyopathy, and arrhythmogenic cardiomyopathy. So if you look at dilated cardiomyopathy, probably around 50% are of genetic etiology. And if you look at the other 3, almost close to 100% are genetic etiology. So before you do any other panel of testing, the only test probably which you have to do apart from echo and ECG is genetic testing in these conditions, because the yield as well as the value of the testing, subsequent management is extremely high in these tests. So that is why, like, for example, if you look at any algorithm to work up cardiomyopathies, it will say you have to send metabolic screening, tandem mass spectrometry, GCMS, lactate, pyruvate. I actually avoid all of that and do only genetic testing, because even if you do all of these tests, it won't still give you a perfect diagnosis, and it will not dictate your management, okay? Whereas this is going to change your management completely, not just the management for this child, but the management for the entire family as well. So next slide. So how genetic testing helps in cardiomyopathies? Prognostication is the most important thing. So there are certain genetic conditions where, irrespective of the treatment, the child is not going to improve. So that is also a very important information which the family should have. So say they have a dilated cardiomyopathy with a very bad genetic subset. That means that we have to consider advanced therapies, like early listing for transplant. So there are certain conditions where even a transplant might not help. So that is again very important information for the family so that they are prepared accordingly. Then most of these are autosomal dominant conditions. So it means that potentially the parents as well as siblings might also be at risk for these diseases. All of them have variable penetration. So sometimes the onset might be much later. So we have had families where, on cascade testing, we have realized somebody in the mother side of the family has the disease, which they were not aware of, and we are able to, identify and treat it early. I hope, with these two case examples, I've shown you that it's not just about identifying family members or prognostication. Even treatment can change based on the genetic diagnosis. Again, the example I chose was rasopathies because that is something which many of you may not be aware of. But POMPase, that is enzyme replacement therapy. And if you start it early, in early infancy, say before 3 months of age, many of them can go on to have near normal life. And there are also other interventions, like, for example, there are certain conditions where the risk of sudden death is very high. You might have to consider an early transplant or insertion of an implantable cardioverter. So these are how it can impact. It's not just about making the diagnosis. It's about more than making the diagnosis well. Next slide.
So going on to the next topic, here we focus on the channelopathies. Channelopathies, we encounter long QT syndrome, Brugada syndrome, catecholaminergic polymorphic ventricular tachycardia, CPVT. So first of all, clinical pointers towards an inherited arrhythmias. So when all should we suspect an inherited arrhythmias? Sudden infant death syndrome, sudden death in young family members less than 35 years of age, more than one drowning death in the family, difficult to control seizures with a normal EEG, seizures with a specific triggers like sudden noise, swimming, fever, syncope on exertion during febrile illness, persistent sinus bradycardia in neonates and young child. So going into the first case, we have in the prenatal scans, this baby showed persistent bradycardia, and then bradycardia was noted in NICU. And this is the ECG of this baby. Here we can see if we calculate the QT intervals, clearly they are prolonged. It will be 520, 560 and 620, 600. So very prolonged QT, if we calculate the corrected QT interval, it is more than 600 milliseconds for this case. So it is clearly more than 460 milliseconds. So this points towards a diagnosis of long QT syndrome. So in long QT syndrome, there are various types of long QT syndrome, and each long QT syndrome has a specific genetic mutation, and each has a specific channel which is getting affected, and each has a specific clinical presentation. And one thing is common where in all the long QT syndromes, the first line of treatment is to go for beta blockers. So for this baby, beta blockers we started. But despite beta blocker therapy, it developed a recurrent syncope. So the next step is to go for genetic testing because mexiletine long QT syndrome type 3 is sensitive to mexiletine therapy. We can find this easily through genetic testing because in long QT syndrome type 3, we have SCN5A mutation. So for this baby, genetic testing was done and it has SCN5A mutation. So this baby was started on mexiletine therapy. Going on to the next case study. 10-month-old child diagnosed to have bradycardia antenatally. Genetics was done in the newborn baby. And this is the ECG of this baby. Here also we can see QT prolongation. And again, this was started on beta blockers, and despite the beta blocker therapy, it had a recurrent syncope. And it was referred for evaluation potential role for the mexiletine therapy. And again, this is the ECG of this baby, and genetic testing was done for this baby, and it specifically showed the CACNA1C mutation, which is typical of Timothy syndrome, long QT syndrome 8, type 8, autosomal dominant. One feature of this Timothy syndrome is that despite the beta blocker therapy, it most often requires an ICD placement. So this baby was immediately has gone for ICD, and then the sinus rhythm was reverted. So long QT syndrome in the neonatal period, it can present as sinus bradycardia, 2:1 AV block. This is an ECG showing a 2:1 AV block. We can see. Next is malignant arrhythmias, polymorphic ventricular tachycardia. If intervention is not being done or if we don't evaluate the case, it can end up and present as a sudden infant death syndrome. So over to Dr. Maniram, sir.
So again, in this case, you had two case scenarios. where the presentation was the same. So both of them presented with antenatally diagnosed bradycardia and postnatal bradycardia as well. So both of them were correctly suspected to have long QT syndrome, and then started on the first line of treatment, which is beta blocker. And both of them did not respond to beta blocker. So we had to do something more than just a first line therapy. And again, when the second line therapy was dictated purely by the genetics. So whenever, like when I was a training in cardiology, it was hardly 10 or 12 years back. Whenever we had a symptomatic infant with long QT3, we knew this baby was going to die because beta blockers alone never works, and mexiletine was not widely available at the time, which was actually very sad because even at that time, more than 90% of the mexiletine produced worldwide was actually manufactured in India, but it was not available in India. So, but now things have changed. So now mexiletine is very widely available, and it is actually not very expensive also. So this particular child now is nearly 3 years old and has not had a single episode of syncope since we started on mexiletine. So, so we were able to completely change the family's, not just the quality of life for the child, but also for the family. So I remember the mother telling on the first birthday that for the baby was first referred to me at I think 6 months of age. Said first 6 months we did not have even a single day of peace, but since we started mexiletine, I'm sleeping peacefully. So that is a kind of impact where appropriate testing and appropriate treatment matters, and especially in long QT and in infants. It is again treatment, yes, but genotype is also the most important predictor for outcome as well. So even prognostication depends on the genotype. Next slide. So generally long QT1 and long QT2, they do very well. So long QT1, if you diagnose in the right time, death is almost unheard of if you manage it properly. So they have near normal lifespans. Whereas in long QT2, there are certain very specific risk factors, which most of them happen in infancy. And if you manage them appropriately, later deaths or later abnormal events are less likely. Whereas long QT3, the risk is very high. Sometimes if it is a mexiletine sensitive variant, like it was in the first case, the outcomes are generally good. But if it's not sensitive, sometimes you might have really bad outcomes despite appropriate management. Next. So for want of time, I focused only on 2 scenarios, but I hope we have managed to illustrate the point that genetic testing is a very important part of clinical management of these conditions. So not just diagnosis, but also further management.
Thank you so much, sir. Those 2 case scenarios were wonderful. Now it's time for the faculty spotlight today. We are very grateful to Prasad Mane, sir, for being with us today. So we would like to hear your thoughts about the case and also your experience and the words of wisdom that we're always eager to hear.
Yeah, it was nice cases. Thanks for IAP Chennai to organize such a nice scenarios. I think these are the 2 cases show how important the genetics are there. But generally for a pediatrician, so these are the cases they may not see that often. The part of pediatrician, what they should know, the first case, obviously there is a developmental delay and there is some mitral regurgitation. The clinical part is always important. Whenever you see the child with developmental delay and with the mitral regurgitation, that murmur, so the importance of developmental delay with the murmur, obviously the child needs an ECG and echo. So that can be sorted. So what next? What we are going to do? So with the arrhythmia part, so the bradycardia is very important. Bradycardia usually in the antenatal time will have there is a possibility of long QT. So sad thing with the long QT, I have seen many. Usually we diagnose the long QTs with the death in a family. So they will always have a family. Even I was in UK there. The first case will be a sudden death. then later on you go back go behind and do the genetics, you will find out. These things can be avoided by prognostication. Whatever we do at the end of the day, we can't really save all the bits. And these presentations will be what we have to the history is very important. Whenever you are asked the history, you have to ask any sudden death in the family under 30, then you'll be careful with the first history and doing an ECG and further clinical examination. So the clinical examination part is very important. So it's obviously it's shown both cases. First two cases shown there is the obviously a systolic murmur, and the second case again is shown the same nuance will have if they have any murmur, if there's something like that such a hypertrophy, you will may have likely the aortic stenosis type of.
I think Sir has got disconnected from our meeting. Let's just wait for him to be back. Meanwhile, Maniram sir, would you just like to add something else?
Well, that's it, ma'am. Nothing more, ma'am. Like if maybe if sir he's joined back. Otherwise, I thought we can go to Thirukumaran's presentation. But sir has joined back, ma'am. So
Yes, sir is here. Sir is here. Prasad sir? So I think in a traditional sense, you know, we've all been taught this way. Exertional chest pain in a young athlete, it raises the suspicion for hypertrophic cardiomyopathy or a coronary artery anomaly. And then, you know, we would say, okay, palpitations, chest pain, and a documented ventricular tachycardia suggest a malignant arrhythmia. So these red flags, along with a positive family history of sudden cardiac death, point to a potentially life-threatening cardiac condition that must not be missed. I think this is the traditional teaching. Today we are wiser because, you know, we know what is latest. Yes, Prasad sir is here. Yes, sir. Sir, over to you, sir.
Sorry, ma, I think it's suddenly it's disconnected.
Yes,
so,
sir. Yes, sir.
Yeah, I think like basically the advancements are always there. So there will be some whenever we see this genetic testing part. So cytogenetic and molecular genetic. I think what Maniram, this case showing more of molecular genetic. So you will have a sometimes very clear answer. It's a variant spectrum. It says a benign or likely benign, likely pathogenic, and pathogenic. So most of the times you will get a variance of uncertain significance. The genetics is really a complex topic, but these are the cases, classical cases, what is shown. Even if you are not getting a classical cases, always there is a genetics, we can involve the multidisciplinary team. And so the essence of this one, so clinical parts, very important, suspect and refer, and there is a possibility of the treatment. And these arrhythmias as presents with the first case may be unexpected death. I think it was nice cases of we can have the further discussion, and as a part of the pediatrician, these are the few things you always keep on mind.
Thank you, sir. Over to Maniram sir for the next part of this session.
the next part is actually interventions, ma'am. So Thirukumaran is presenting it. So interventions is something very hardcore cardiology, which so we have tried to make it. We've chosen 3 specific scenarios which pediatricians may not be aware of, which can be dealt without by a transcatheter intervention, and where the initial presentation is to a pediatrician. So Thirukumaran, can you share your slide?
Good evening, respected sirs. I am feeling overwhelmed to share space with you. I am going to share my screen. Over to Dr. Maniram sir for the initial few slides.
So next slide. So actually, I think no, previous slide. So I think congenital cardiac interventions have evolved quite a lot, especially in the last decade. It's due to a combination of factors. First is our understanding of embryology and anatomy have improved so much. So certain things which we thought were outside the spectrum of interventions have been included now. And imaging has advanced significantly. It's not just echocardiogram. We have much better tools as well. So we have CT, we have MR. We also have 3D modeling, and we can look at all of these in virtual reality as well. Again, there's bedside availability of ultrasound. So we have three-dimensional transistor-visual echocardiogram to guide our interventions. The quality of equipment which we have on the bedside is much better. So, like for example, you have a sick newborn, you need to first suspect and confirm a cardiac diagnosis in the bedside before you do more advanced imaging modalities. So that is an important part of thing. And again, the hardware have also improved significantly. So they've not just got refined, but they've also become much smaller. So you're able to have catheters which can be used in babies who are less than 1 kilogram as well. And what is more relevant for our setting is, the advancement of this technology has also, there's also a decrease in the cost, which has made it much more affordable for families, in our region as well. Next. So this was actually, we are actually looking at this in VR. So this is the CT of a baby. So we are looking at it in VR. We are able to go from the chest into the heart. We are able to identify where exactly the hole is, and we are able to plan the intervention. We can actually do the intervention in virtual reality. So I was not able to get a video of that ready in time for this presentation, but hopefully some other time I can show it. So we actually, for example, in the sinus venous defect is one aspect which we'll be covering with the case scenario here. We can actually place the stent in virtual reality to see how it's going to fit in that particular patient's heart. And that is something which is not just cool, it also makes us more confident when we go and do the procedure. Next slide. So we are going to focus only on 3 interventions today for lack of time. The first is preterm PDA. The second is sinus venous defect. And third is Abernethy's malformation. And Thirukumaran is going to take over and show you some.
Thank you, sir. Presenting the first clinical case scenario. This is a preterm, extreme low birth weight, born out 27 weeks of gestation with a birth weight of 900 grams. The baby was initially ventilated for 4 days and extubated successfully to CPAP. Sepsis was treated, and baby achieved full OG feeds, but it was unable to wean the baby from CPAP. The weight of the baby at 37 days of life was 940 grams. The initial chest X-ray picture showed a cardiomegaly and mild haziness over the right lungs. The echocardiogram of the baby, which shows the left pulmonary artery duct. This is the left pulmonary artery and duct and descending aorta. In this, it's obviously clear that the duct is larger when compared to left pulmonary artery, which is approximately more than 3 mm in size. So this needs closure. This is the angiogram. The catheter is placed in the duct. The duct is between the left pulmonary artery and the aorta, which is the ductus arteriosus. It usually closes soon after birth when the baby starts to inhale the breath. The flow of oxygenated blood across the ductus causes vasoconstriction and closure of the duct. But if it fails, it leads to patent ductus arteriosus. And here the catheter is placed in the duct, and now the blood starts to flow from the aorta to the left pulmonary artery from 4 o'clock to 10 o'clock position. And in this second angiogram, we are deploying the device over the duct. The device consists of 3 parts: the aortic disc, followed by a central portion, and followed by a pulmonary disc. This device has been deployed in the site of the duct. And this video shows the device which we have deployed is intact in that place. And following successful treatment, there has been a significant improvement in the chest X-ray of the baby compared to the initial picture. And things to note in patent ductus arteriosus is what are all the cases we have to close, and which cases that doesn't need closure. Hemodynamically significant PDA is there. What is hemodynamically significant PDA? We have to confirm by either clinical criteria with echocardiogram findings. Echocardiogram findings are gold standard to confirm it as hemodynamically significant PDA. Clinically, how we can suspect a baby which is going to have PDA? There will be hyperdynamic precardium and bounding pulses will be there with wide pulse pressure. These are the clinical clues before suspecting PDA. If a baby is having these findings, we have to perform an echocardiography. In echocardiography, we have to look for 3 things which are gold standard to confirm it as hemodynamically significant PDA. The findings in echocardiogram will be ductal diameter will be more than 1.5 mm, and the ratio of left atrium to the aorta will be more than 1.4 to 1.5, which suggests of there is so much of blood is pooling into the lungs, so that the left atrium to aorta ratio is more than 1.4 to 1.5, and there will be retrograde diastolic flow. That is backflow of blood in the descending aorta. These are all the features suggestive of hemodynamically significant PDA. And initially, we will start with medical closure therapy. Commonly used drugs are paracetamol, indomethacin, and ibuprofen. And certain contraindications are there for initiating closure therapy, like active hemorrhage, thrombocytopenia, platelet count less than 50,000, and NEC, and if the urine output is less than 1 ml per kg per hour. These are all some contraindications, but paracetamol does not meet those contraindications. It can be given. Indomethacin relatively decreases the risk of intraventricular hemorrhage, and the only side effect is it will lead to oliguria and ischemia. For surgical closure, we have to look if medical therapy fails, then we have to go for surgical closure. Surgical closure devices will be shown in the upcoming slides. After the further management, after successful procedure, the baby was weaned to nasal prongs immediately post procedure, and the baby was switched to oral feeds over 3 days and shifted to ward. Potential complications where we are due to the closure devices can be the device can lead to left pulmonary artery obstruction and aortic obstruction, device embolization, and tricuspid valve injury. The normal next.
Just a couple of comments, Kumaran.
Yes, sir.
So yeah, as far as PDA closure in a newborn is concerned, as a cardiologist, we are only technicians in this procedure. So the decision making is usually the neonatologist decision making. And again, we all know this hemodynamically significant PDA. But even if you have a hemodynamically significant PDA, the decision to intervene is purely clinical. So if you're not able, if you have NEC, if you're not able to wean off respiratory support, or if you have intraventricular bleeds, then those are the patients where you have to close the PDA early. And generally, from our experience, what I've learned is that 2 to 3 weeks is the cutoff. So if you have, if you're not able to wean off CPAP, or if you're not able to reach full feeding by 2 to 3 weeks, and there is a significant PDA, then I think there is a point where you have to probably decide about period closure.
Moving on to normal anatomy of the portal venous system. Normally, the portal vein is formed by the combination of superior mesenteric vein and splenic vein. These two veins join together to form a portal vein. Now we are moving on to the Abernethy malformation. There are two types in Abernethy malformation, type 1 and type 2. In type 1, it is further divided into type 1A and 1B. As we are seeing in this image, type 1A will have both splenic vein and superior mesenteric vein will be separately draining into the systemic vein. Whereas in Abernethy type 1B, splenic vein and superior mesenteric vein will form a common trunk and they drain into the systemic vein. In type 2, the intrahepatic portal vein will be intact. Whereas in the previous two types, type 1A and 1B, the intrahepatic portal vein will not be seen. But here, the intrahepatic portal vein will be intact, but some of the portal flow is diverted into the systemic vein through abnormal vascular channel or side-to-side shunt, as seen here. Normal portal venous circulation. Portal vein carries the blood from GIT, spleen, gallbladder, pancreas, and it ultimately drains into the liver. The liver functions as the reservoir where it detoxifies the blood, removes the active metabolites and cytokines. Portal vein contains nutrients and toxins extracted from digested contents. Detoxification of various substances occur in the liver, for example, ammonia, and various vasoactive substances like cytokines. Here in Abernethy malformation, what happens is the liver has been bypassed so that the blood collected from the mesenteric GIT, spleen, and gallbladder does not reach the liver, so that there won't be any breakdown of vasoactive substances and metabolites, mainly endothelin 1, which is a vasoconstrictor, and histamine, serotonin, and gut-based endotoxins will be there. They won't be filtered. This is the humoral hit theory, and followed by a mechanical hit theory. A mechanical hit theory is there will be, since the liver has been bypassed, there will be no natural resistance to the blood flow. So there will be a sudden rush of blood from high pressure gastrointestinal system to a low pressure systemic venous system. Owing to this increased blood flow, there will be more venous return to the right side of the heart, owing to right atrium and right ventricular overload, followed by this overload leads to injury to the fragile endothelial cells of the pulmonary arteries. This fragile endothelial cells of the pulmonary arteries are more prone for shear stress, leading to development of pulmonary hypertension. The type of pulmonary hypertension developing in this scenario has a specific name called as portosystemic pulmonary hypertension. As discussed earlier, the clinical presentation of congenital portosystemic shunts are pulmonary hypertension, as explained by the above two theories, humoral hit mechanism and mechanical hit theory, followed by cyanosis and paradoxical embolism. Since the blood has not been detoxified by the liver, ammonia will not be detoxified, getting deposited in the brain, leading to hepatic encephalopathy, and which is characterized by development of behavioral abnormalities. When to treat? If the patient is symptomatic, consider closure of shunt. If the patient is not symptomatic, then we have to monitor for ammonia serially. And in the course of monitoring, if the patient develops symptoms, then we have to consider closure. In adult, no matter what, if the adult is symptomatic or asymptomatic, it does not matter, we have to close. In children, we have to look whether they are symptomatic or asymptomatic. If symptomatic, we have to look whether it is mild or mild, severe, or it's not symptomatic, just an incidental finding. If the child is having mild or severe symptoms such as encephalopathy, liver nodule, portopulmonary hypertension, then we have to consider for intervention. If there is no symptoms, just an incidental finding, then we have to look whether it is intrahepatic or extrahepatic. If it is an extrahepatic scenario, then we have to consider intervention. If it is an intrahepatic scenario, then we can wait for 1 year. We can wait for 1 year and watch whether it is regressing or not. If there is regression, then if there is no regression, we have to intervene. If there is regression, no need to treat. How to close the shunt? Transcatheter intervention is always preferable because it is less invasive and there is less morbidity. Surgical ligation is preferred when transcatheter intervention is not possible, like side-to-side shunt. And if the transcatheter intervention has been failed, then we can opt for surgical ligation, where we have to choose liver resection. When there are intrahepatic shunts and multiple large multifocal intrahepatic shunts involving a segment of the liver, then we have to go for liver resection. When liver transplantation is a choice, when there are large multifocal intrahepatic shunts involving multiple segments. Liver resection is involving a segment of a liver, whereas if multiple segments have been involved, then we will opt for liver transplantation. And a special condition where there will be type 1 extrahepatic shunt with failed balloon occlusion test. What is balloon occlusion test? It is a temporary trial run of closing the shunt, because we cannot simply block it permanently without testing whether the liver and vascular system, how they will react. So we cannot permanently close without testing. So we have to run a trial run. We have to do a trial run. This is the balloon occlusion study. What they will do, they will inflate a balloon to fully block the flow of blood through the shunt for about 15 minutes. Then during that time, they will monitor the real-time pressures and take contrast X-ray images. Then venogram. Once the data is gathered, balloon is deflated, restoring the normal blood flow. The usual cutoff for the pressure is 30 millimeter of mercury. Below 30 millimeter of mercury, we can undergo single stage closure. Whereas if the pressure exceeds 30 millimeter of mercury, then liver transplantation is the only choice. And what balloon occlusion study additionally helps is, it helps in identifying the intrahepatic portal venous branches, whether they are intact or not, which are usually not visible. Over to Dr. Maniram sir for the next few slides.
Thirukumaran, this is a very important concept. So thank you for explaining that nicely. So what happens is, generally the portal venous pressure is around 15 to 20 millimeters of mercury, whereas the normal IVC pressure is 0 to 6. So whenever there is a connection between the portal vein and the systemic veins, the portal venous blood will take the path of least resistance and go to the IVC. It will not go to the liver at all. So when you inject into the portal vein, you will not see any portal venous radicals. That does not mean that portal vein is not present. It just means there is no flow going. So you have to make sure that the portal vein radicals are there. How do you do that? What you do is you have to occlude this shunt and then inject to see how it is going. So what you do is we keep one catheter in the portal vein, and then we place a balloon across the IVC where the shunt comes in and occlude it. So you can see this balloon which is dilated, and there is a simultaneous catheter in the portal vein. So next slide. Again, I'm just going to show these angios for comparison. Can you play the videos? So unfortunately, the video is not playing. So what essentially what was there was, in the baseline on the left side, when we injected, we could not see any flow in the liver at all. Next. Whereas after occluding, when we injected, we were able to see flow in the liver. Next. So this told us that this was a successful balloon occlusion test, and we were able to conclude that we can close this defect. Next. So certain conditions, you can have a failed balloon occlusion test. This was a 1-year-old child where there was a very tortuous Abernathy malformation. And when we occluded with the balloon, there was an immediate rise in the portal venous pressure from 4 to 40. So as Thirukumaran had mentioned, the standard cutoff is 30 millimeters of mercury. And here it was much more than that value. And when we injected, there was no portal venous branch visualized even after occluding the shunt. So this told us that this was probably a type 1 kind of Abernathy, where the only option is to do a liver transplant. Next. Next. So these are some of the devices which we use for interventions. We can use coils. We can use something called the vascular plug. Next. And we don't have any specialized device for Abernathy malformation. So we use devices which are developed for other purposes. So we use PD devices. We use ASD devices also in very large shunts, and BSD devices. Next. So again, this is a type of Abernathy which is usually very tricky to manage. It's a side-to-side connection where it is very short, and traditional devices will not hold. But we have some special devices which are appropriate even for these situations. Next. So with that, there's a third case scenario, which Thirukumaran is going to explain. And this is the last scenario, so we're coming towards the end of the presentation.
Thank you, sir. The final scenario is sinus venosus defect, which is a specific type of atrial septal defect, which is a hole in the wall that separates the upper two chambers of the two chambers of the heart, that is the right and the left. Actually, now it's not considered as a atrial septal defect. This is the sinus venosus defect. As seen, it's a defect in the wall, which between the right defect in the wall between SVC and the right upper pulmonary vein. Most commonly, this defect happens at the top of the atrial wall, where the superior vena cava connects to the right atrium. Because of this specific location, sinus venosus defects are almost always paired with another structural anomaly called partial anomalous pulmonary venous return. Normally, the pulmonary veins carry freshly oxygenated blood from the lungs back into the left atrium. In a sinus venosus defect, one or more of these veins from the right lung abnormally connect directly to the right atrium or the SVC instead. This setup creates a left to right shunt. The oxygen-rich blood that just came from the lungs slip through the defect right back into the right side of the heart. This causes the right atrium and the right ventricle to work overtime, continuously pumping extra already oxygenated blood back through the lungs. Long-term outcomes, the complications following the surgical closure of sinus venosus defect were SVC obstruction, pulmonary venous obstruction, and sinus node dysfunction. Prerequisites: CT angiogram, initial few cases. Excuse me, sir.
So I think I'll take over from here. So sinus venous defect, generally, traditionally we do surgery. Surgery is sort of gold standard, which has existed for more than 60 years. And the long-term outcomes are generally excellent. Okay. So the complications which you mentioned, probably all of them put together, they may occur in, I will say, less than 5% only. So more than 95% have a very good outcome, and it's fixed for life. But there are certain patients, especially in our parts, where generally surgery has a lot of bad social impact on the family. So obviously this is what is termed open heart surgery, and there are a lot of misgivings in the family, in most families, about undergoing open heart surgery. So which is why we looked at other forms, and this is transcatheter intervention is definitely possible. And it is possible even in resource limited settings. So these are some of the prerequisites. And you definitely, at least in the first few cases, we need a CT angiogram to see if there is any unfavorable features. So what we essentially do is, next slide. So what we look for on the CT is, so we have to see the relationship of the right upper pulmonary vein, whether there is only one vein or multiple veins, and where exactly they join. Next. And most importantly, we need to know where the orientation of the right upper pulmonary vein is. So even though there is partial anomalous pulmonary venous drainage, it is oriented towards the left atrium only. So as long as that orientation is maintained, you can close it without surgery. Next. We measure the length of the defect, and we also do complex multiplanar reconstructions to understand the defect in a three-dimensional aspect. Next. And we also need to look at the length of the defect to understand how long a stent we need to place. Next. So I'll quickly go through the procedure first. The first step is you do what is called a transeptal puncture. So you need to access the left atrium from the right atrium. So we choose a point below the sinus venous defect, perforate the atrial septum, go into the left atrium, and from there we cannulate the right upper pulmonary vein. So, and then next step. Next slide. The next slide is we do a balloon occlusion, very similar to what we showed for the Abernathy malformation. So what you do is you occlude the sinus venous defect with a balloon, and you look to see if the pressure increases, like we saw in Abernathy malformation. So the pulmonary venous pressure should not go up by more than, the traditional cutoff is 2 millimeters of mercury, but sometimes we accept even 5 to 6 millimeters of mercury increase in pressure. And the second thing we look for is, if there is any shunt despite occluding. So we give an angiogram to see if there is any left-right shunt. So in this particular patient, there is no obstruction of the pulmonary vein, and there is no residual shunt after occluding with the balloon. So once we have this information, next one. Next slide. So we use a covered stent. So generally you have two types of stents, an uncovered stent or a bare metal stent. So, in a bare metal stent, there'll be holes through which blood can pass. Whereas in a covered stent, the entire stent is covered by a membrane. Typically, the membrane we use is Gore-Tex or what is called PTFE, polytetrafluoroethylene. So this prevents blood from flowing across the stent. So we mount it on a balloon and then deploy the stent across the defect. Next slide. And sometimes we might have to dilate the upper and lower parts, make sure it gets, if there is any restriction, we make sure that we eliminate it by dilating it with a larger balloon. Next slide. This procedure is also not completely free from complications. Certain complications can still occur. We divide them into three major subsets. The first is vascular-related complications. You can have damage to the femoral vein. The second is, you might have a right upper pulmonary vein obstruction or a restoration. And sometimes once you deploy the stent might move or it might get blocked off. Again, we have techniques to manage all of these without surgery. But in rare case scenarios, we might still have to go and do a surgery. Next. So I've not gone into all the aspects of interventions in today's talk. We've just focused on three things, which most of you may not be aware of. I think basic things like, device closures of atrial septal defects, ventricular septal defects, ductus, balloon valvotomies, all of you will be aware of. But these are, sort of niche procedures which many of you may not be aware of, which is why we chose to focus on this. So if there are any questions or comments, we are happy to take.
Thank you so much, sir. May I request Prasad, sir, to offer his expert comments?
Yeah, again, the nice cases. Maniram did very well with that one. A few comments for the particularly, this is not a cardiology people, what we are dealing, the pediatricians are here. The PDA part, I think people are doing less than 700 grams, for more than 700 grams and more than 3 days. This is the cutoff. The US people are very aggressive. They were closing these PDAs. And here what for us, he explained nicely the indications for when to do, what to do. It's a communication is a very key here. The vascular issues will be always there. Sometimes I have seen even the limb ischemias with these things when you are doing these things, and the communication part is very important. And these are having high complications with the small babies undergoing, because they already have the morbidity with their preterm. That part you have to remember. And the recent European studies are showing that not much use, even if you do these PDAs early. So there is no difference between the long-term morbidity. So that we have always have to keep on mind. When second case comes Abernathy, that I just want to add, these are the fetal diagnosis. So we don't even see. I have in last 20 years, I have seen some 7 cases, and these are mainly the fetal diagnosis. But as a pediatrician, you may come across these cases with they may present with a pulmonary hypertension, unexplained pulmonary hypertension. You have to suspect. Again, it's a clinical diagnosis. Your P2 will be loud, and then you see the cyanosis. So this is the basic test we always miss. We ask always, whenever you see the baby, ask your staff nurse to see for the saturations. Sometimes you can pick up these things. So Abernathy, it has, if you have, it has a different complications. As he mentioned nicely, you may need a liver transplant. It's a long-term prognosis. It's very rare things. The third thing, SVC ASDs, again, I think it's here the communication is very important. These are the last I think last 10 years we are all doing these SVC ASDs. We need a still long-term studies before we are going to come. As he mentioned, surgery is there for the last 60 years, and the people people know so what are the complications. I've never really seen any SVC obstructions over last 20 years, and not much complications with these SVC by surgical. But intervention, it's a new techniques, and without, we're not supposed to go for a medical legal issues. As a pediatricians, it's very important to say that both techniques are there. So these are the without the scar, with the scar. So what are the complications? And that way it will always help. Intervention always it's a double edge. The important part is from all of us to communicate well. And SVCAS, this is a common diagnosis missed by the pediatricians. So it's very important, again, your clinical skills to have the split. I think here we got our teachers, particularly Dr. Srinivasan and SBS sir. I worked with them for the last 15 years with the SBS sir, and he's always ready to pick up clinical things. As this is even though we're talking about advanced, we never forget about our basics. So picking itself is very important. When you SVCASDs, sometimes it may be lot, not if it is a small, sometimes it may not produce even symptoms till third or fourth decade. So it's important, again, it comes to the point of clinical things. It was nicely organized, this session, and the teachers are great there, the clinicians. Even though we are talking about all these advanced things, we'll essentially will end up with the basics, and we'll just to go ahead. It was nice sessions. It's nicely presented, all nice 6 cases.
Thank you so much, sir. I think Prasad sir is proof that, for pediatric practice, not just knowledge you need, but pragmatic wisdom. Thank you, sir. Whatever you spoke truly reflected that ethos. May I request our convener, SBS sir, to offer his closing remarks for today.
Brilliant session. I'm amazed at the technological advances and the way Maniram took us through the case scenarios with interventions, curing the illness. Fantastic. I have a few questions to Maniram and Dr. Prasad. One is when you do all these interventions, what happens to the risk of infective endocarditis? That's one. 2, what happens to the risk of thrombosis or embolism And but I have seen a few patients receiving aspirin or clopidogrel, few patients not being given. What is the protocol that you all follow? And third, and as a general pediatrician, suppose I see a child or an infant who has undergone an interventional procedure, and when the child comes to me with fever, when do I stop thinking of infective endocarditis? These are the three questions and doubts I have. Thank you.
Sir, generally, sir, device-related infective endocarditis is extremely rare. So I have personally not come across a single case. Yes, there are reported cases, but they are extremely rare, sir. And most of these devices, like EST, VST, PDA, they endothelialize within around 6 months. Sir. So what happens is the endothelium grows around the device, which means that the risk of endocarditis is not very high after that. So typically it is 6 months. Sometimes it might be higher. Sometimes endothelialization may happen only 2 to 3 years later. But typically it is around 6 months. So this is the period where the risk of infective endocarditis is very high. And the most important aspect is good dental hygiene for this. So that is why actually even before we close the device, at least that is my practice, we now counsel them about dental hygiene, make sure they have a dental checkup before I submit them to a device. At least patients who come privately through my clinic, this is my protocol. So they have a dental checkup, they have some dental advice before they go to the procedure. And if you maintain good dental hygiene, you significantly reduce an already small risk. So essentially, the risk is extremely low. And regarding the use of aspirin and clopidogrel, so typically in ASD and VSD, you use aspirin and clopidogrel because there might be platelet aggregation in the first 6 months. So you don't use it for a coagulation risk, but you use it because there might be platelet aggregation across the device in the atrial septum and ventricular septum, because these are slightly low pressure chambers. So ventricle is high pressure, but in diastole the pressure is very low. So what happens if there is platelet aggregation is there might be microthrombus which might go into the brain. So that can result in migraine, and migraine can be very incapacitating for a few patients. So that is the reason why we use aspirin and clopidogrel in typical shunts. Again, we use it for 6 months. Usually we use only a single antiplatelet in children. Only in adults we use dual antiplatelet. In sinus venosus defect, that is one place where there is a small but substantial risk of thrombosis. So there you use dual antiplatelet. So typically we use aspirin and clopidogrel. Aspirin at a dose of 3 to 5 mg and clopidogrel at 1 mg per kg. And your third question, when do you think of infection related to a device? Again, I think it's extremely rare. So if probably a fever continues for more than a week, and this is in the first 6 months, so maybe you need to think of an infection related to the device. But for a typical 1 day or 2 day fever and what looks viral clinically, I don't think you have to press the panic button.
Thank you. Thank you very much. Brilliant sessions.
So it's a
Over
very
to-
valid question, sir. I think this is what the pediatrician will always have. So when we are talking about the intervention and surgery on these things, when we are communicating with the family, initially itself, it's very important. So we say like no scar, then we go for an intervention. So we have to always explain. I have seen some 3 cases of infective endocarditis after the devices. But these 3 cases again, like they presented fever for more than 20 days, 21 days. So when the fever is not even, if it is more than, again, we work like to do the blood test and just to make sure. Usually they don't really collapse or nothing will happen during that fever time. But it's highly recommended if the fever lasts for more than 10 days. So we always think about that. Is possibly with the intervention. This I have seen over the last 20 years, not last few years. It's over the 20 years. And the second thing, aspirin we will give for only for ASD, and the dual will be. Recently, I have seen one case where we close the ASD. we have to make sure there is no thrombotic history in the family. There is a family history of thrombosis in the father that we didn't get that history properly. So when we did the ASD, so there is this thrombus, it's persistent for a long time, and we are still treating with the anticoagulation. So I think the history of thrombosis in the family and the parents are on some medication, it should be worked out and before thinking about the intervention part. Other than that, I think the intervention is quite safe, and nowadays it's a well proven over the last 20-25 years. It's a well proven thing. But it's a counseling part is very important. So this we can expect any complication at any point.
Thank you so much,
Thank you.
sir. Thank
Thank
you,
you.
sir. SBS, sir, anything else, sir, from your side?
Nothing else except congratulations to and blessings to Maniram, and of course thanks to Prasad Mane, who's an absolutely brilliant cardiologist. Thank you.
Thank you so much. With that, we come to the end of this pediatric cardiology exclusive RUPE session. On behalf of IAP CCB, we are very much grateful to our convener, of course, SBS sir. He is the Bhishma Pitama of pediatrics. Thanks to you, sir. Thanks to Prasad Mane, sir, clinician, cardiologist par excellence, and of course, mentor Maniram, sir. Your students just knocked it out of the park. Thirukumaran and Viveka, they presented so confidently that it made me feel like a caveman. The only thing that I kind of remember about interventional cardiology is that, okay, in an ASD, if there is a deficient IV serum, sent to the cardiothoracic surgeon. So that's the standard where we are. And today it was awe-inspiring to see both the students present so confidently. It looked like a PCSI, platform session. It was like a PCSI session. So great job. The students did a wonderful job. Of course, it speaks volumes of your mentorship, sir. We would also like to thank the HOD of Tanjavur Medical College, Professor Selvakumar, sir. So, he has allowed the students to graciously participate in this session today. I would also like to thank our President, Sudhakar, sir. He's the man with a plan always. He's the brain behind RUPE. Thanks to you, sir, for joining us, our treasurer, Dr. Anandi, and the EB members who were with us today. My pranams to senior teacher, Srinivasan, sir. It's very inspiring to see him attend these sessions. He's been with us for the last 2 or 3 sessions. My pranams to you, sir. Thanks to everybody who joined us tonight and who made this event so enlightening. It was wonderful. Words fail me today. Really brilliant presentations today. And this session, it's been live streamed on YouTube. It will be there on our YouTube channel. Please subscribe to the IAP CCB YouTube channel. With that, let's wind up today's session. Till we meet again next month. This is Team CCB 2026. Good night, everyone. Thank you so much.
Thank you, ma'am.
Thank you.
Thank you, SBS sir, Prasad sir.
Thank you, all of you. Thank you, Dr. Maniram. Excellent presentation, Doctor. Excellent coordination between your students and you, actually. That's a highlight of this today's program.
Sir, I should congratulate both of them, sir, because as I mentioned,
And the teamwork of coordination between the thing is, the presentation between the slides, giving your highlights, and really, really amazing. First time we are coming in such a program in recent update, RUPE.
Yeah, it was very, very nice today. And of course, SBS sir, he always finds ways to make our programs so attractive. Janaranjagama akardu vandu, sir only knows how to do it. Sir, what RUPE is today, we totally owe it to you, sir.
Yes, sir.
My pranams to you. Thank you, sir.
Thank you, all of you. Dr. Prasad Mane, thank you, sir. Thank you for coming up with even a short notice.
Thank you, sir.
Thank you, sir.
Thank you so much, Prasad, sir. Thank you, sir. Good night, everyone.
Good night. Good night.
Thank you, sir. Thank you, ma'am. I would like to thank Dr. Maniram, sir. He meticulously prepared all the material for this presentation and he guided us really well. And I think it is very rare for us to find an opportunity to collaborate with a specialist. So I really thank the IAP CCB forum for providing me this opportunity to collaborate with the specialist at the first place. As a first year PG, it was a really honor to share this space. So, and I also like to thank our HOD for providing an opportunity to take participate in this. Thank you so much. And I thank Dr. Prasad sir for enlightening us with many points. And I definitely thank our mentor, sir, Dr. Maniram, sir. Thank you so much, sir. Thank you, ma'am. Thank you, sir.
Thank you.
A special thanks to Dr. Maniram sir for meticulously guiding me, ma'am. Without him, this presentation was very difficult. He guided me. He taught me very well. I understood, first of all, before expressing, which I felt was a blessing to communicate with a specialist like Maniram sir. And I express my sincere thanks to our department HOD sir, Selvakumar sir, for letting us to participate this event, ma'am. Thank you.
Thank you so much.
God bless you, both
நீங்கெல்லாம்
of you.
fellows-ஆ
God bless
PGs-ஆனே confusionல இருந்தேன் கொஞ்ச
I was
நேரத்துல.
also wondering, first year PGs அப்படிங்கிற மாதிரி.
Very nice. Thank you. Thank you.
Okay.